Up next, Chris Kopinski, pharmacy manager at Southern Oncology Specialists in North Carolina, will now deliver our Clinical Corner presentation sponsored by Tercera Therapeutics. This month's Clinical Corner discussion is on oral Varubi for chemo-induced nausea vomiting. Chris.
All right. Hi, everybody. So like Stephen mentioned, this discussion is going to be on the oral Varubi. So it's a novel prevention of delayed chemotherapy-induced nausea and vomiting for patients receiving highly immunogenic chemotherapy regimens. Next slide. And then, so this is going to be a CINV overview. So basically, what is chemo-induced nausea and vomiting? Basically, there's two phases to it. There's an acute phase and a delayed nausea and vomiting phase. The acute phase is the first 24 hours that from when the patient gets their chemotherapy, and the delayed phase is days 2 through 5. The highly immunogenic chemotherapies have a 90 or greater % chance of causing nausea and vomiting, while the moderately emetogenic chemotherapies have a 30 to 90% chance of causing nausea and vomiting. So that is a high chance for patients there. The NCCN guideline recommendations for low emetogenic risk is going to be dexamethasone with a 5-HT3. The moderately emetogenic, you have 3 different options there: dexamethasone with 5-HT3, dexamethasone, palnositron, and olanzapine, or dexamethasone, 5-HT3, and an NK1. So in this case, Varubi would qualify there for patients with some of those additional risk factors. And then the highly emetogenic regimens, there's a recommendation to use kind of a combination of the previously mentioned NK1s, 5-HT3s, dexamethasone, and olanzapine. Those risk factors that we talked about before, some of the ones to look at are the specific chemotherapy agents. Are they using one agent, multiple agents, and what are the risks for those? The schedule and route administration, so how often are they getting this chemotherapy? Is it weekly, bi-weekly, monthly? And then there's individual patient factors, so age, sex. So in this case, females are more predisposed to having nausea and vomiting from their chemotherapy. Had the patient had previous chemotherapy, whether it be the same kind or different, and that was one of the side effects they experienced was nausea and vomiting. And then actually history of low alcohol intake. So patients that do not drink often at all actually have a more susceptibility to have nausea and vomiting. So some key important facts with this: if you properly prophylact a patient with highly immunogenic chemotherapy, you can really reduce their risk from 90% to 30%. So that's a massive 60% decrease to really help patients so they're not having a bad time with their nausea and vomiting. And then delayed nausea and vomiting is more common than acute nausea, and it's often more severe and can lead to some of that treatment discontinuation or delays in their treatment. Next slide. So CINV, why is that a big side effect that we should really care about, basically? So there was a study done where patients identified what side effects they would find favorable or more tolerable than other side effects. And in this case, chemo-induced nausea vomiting was by far the worst side effect that patients thought about when they related to chemotherapy. You can see that was the worst one, going down to mucositis, diarrhea, febrile neutropenia. I don't think that's really a shock to any of us, as I think most patients, when they hear chemotherapy, they instantly think of nausea and vomiting, no matter what the chemotherapy is. And moving on to how that affects our healthcare practitioners, 32% of healthcare practitioners, that data was taken from this study for the prior year, they delayed or discontinued that chemotherapy due to that chemo-induced nausea and vomiting. So you're really disrupting patients' care and their treatment. You're not having them have an optimal outcome with that treatment regimen. And then this slide discusses how chemo-induced nausea and vomiting works, where it kind of happens in the brain and the body. So the brainstem is where you're going to have your NK1 receptor. So Varubi is going to be working in that aspect. And substance P there primarily mediates the delayed phase of chemo-induced nausea and vomiting. And then in the GI vagal afferent nerve fibers, that's where the serotonin and 5-HT3 receptors are highest. And that's where serotonin is going to mediate the acute phase of chemo-induced nausea and vomiting. And that's why it's really important to have that two-pronged attack at the NK1 receptor and 5-HT3 to have that protection against the chemo-induced nausea and vomiting. Next slide. This image is a great image for practitioners or patients alike to see that not all chemotherapy is alike. Whether it be highly immunogenic or moderately, they act differently to each patient. So in this case, cisplatin, you can see when patients get their infusion and closely afterwards, it really peaks in their acute nausea and vomiting and then fades away by the end of the first day. And they have the day to 2 days where it's typically on the low side and then it starts to peak again at day 3. So that could be a problem in patients that think that their nausea is done, maybe don't use their rescue meds or don't think about their nausea and vomiting, and then it kind of hits them in the wave and they're playing catch up there, which is always difficult to do. And then you have drugs like cyclophosphamide or carboplatin that are going to kind of plateau up there and slowly work their way down across. So it's really important to have full coverage on that acute phase and delayed phase, no matter what chemotherapeutic agent you're having, because some patients experience it at different times. Next slide. So Varubi, the dose of Varubi is 180 milligrams. It comes in 2 90-milligram tablets. You're going to use it in combination with other antiemetic agents, so a 5-HT3 and dexamethasone in there. It's indicated for adults in the prevention of delayed nausea and vomiting associated with initial and repeat courses of immunogenic cancer chemotherapy. It's including but not limited to highly immunogenic chemotherapy, so it works for other severities of chemotherapy as well. The contraindications there, so there's really only 2 big ones: any hypersensitivity reaction that patient has to any component of the product, and also if a patient's taking a CYP2D6 substrate of some sort like thyroidazine or pimozide. It influences the plasma concentrations, which can lead to cardiovascular risks, so QT prolongation, torsades, things you really want to avoid a patient from having. So that's something you have to counsel a patient on and verify with their medications. And then slide. So other important safety, just like we said, the CYP2D6, one thing to note that is even though this drug treats the delayed phase of the nausea, it does not immediately exit the body after after 5 days. It's still going to keep those concentrations high for at least 28 days. So it's not recommended to maybe stop those medications for 5 days and restart it, because those concentrations are still going to be effective and you could still have those cardiovascular risks. So it's better to change medications or kind of find an alternate therapy there if you can. Next slide. So Varubi is a durable, highly selective antagonist of the NK1 receptor with a long half-life. So like we mentioned before, it works on the NK1 receptors. That's where the mechanism of action is, which is great since we cover one base and then we want to use something else to cover the 5-HT3 side. It has a long half-life of 7 days or 180 hours. It's administered on day 1 of chemotherapy. It actually can work for more than 2 weeks without needing another NK1 dose. So if someone's getting weekly therapy, that's something to kind of note there. And it has high selectivity and affinity for the NK1 receptor, so you're really targeting that delayed chemo-induced nausea and vomiting. Slide. This quick chart, the main thing to take away here is to really look at that half-life. You can see how Varubi almost doubles the next closest agent in half-life, so meaning it's really going to be in that patient's body working on all the way through that delayed chemo-induced nausea and vomiting. And you can also see that the dosing does not change, whether it be HEC or MEC or any kind of dosage adjustments necessary here. So next slide. So this is a primary endpoint of 2 highly immunogenic chemotherapy studies. There's a complete response in the delayed phase of chemotherapy-induced nausea and vomiting. So in this study, they looked at the phase from 25 to 120 hours after chemotherapy administration. So these patients received cisplatin at a dose of greater than 60 milligrams per meter squared. The patients in the study, 40% were lung cancer, 20% were head and neck cancer, and 9% were ovarian, and then it went into smaller subclasses from there. So study 1 had 532 patients, study 2 had 555. There was a 1-to-1 randomization. Varubi was given at the 180 milligram dose 1 to 2 hours prior to chemotherapy, or a placebo was given. At the 30-minute mark, they received their 5-HT3 and dexamethasone, and then the chemotherapy was induced. And then on days 2 to 4, dexamethasone was continued with the oral dosing there for 8 milligrams twice a day. Next slide. And then there was also a primary endpoint for the moderately immunogenic chemotherapy study. They were trying to just compare the moderate versus highly immunogenic and how Varubi worked in that aspect. They looked at the same factors of 25 to 120 hours after chemotherapy administration. They use a variety of drugs: carboplatin, cyclophosphamide, irinotecan, oxaliplatin, doxorubicin. So you can really show how it works with a variety of chemotherapeutic agents, not just a select few. The study included 63% breast cancer, 15% lung, and 5% ovarian cancer patients, and then smaller subclasses from there. Again, the dosing was similar with the 1 to 2 hours before with Varubi or placebo, 30 minutes with 5-HT3 and dexamethasone, and then days 2 and 3 in this case was actually continuing the 5-HT3. Next slide. So the study results for prevention of delayed chemo-induced nausea and vomiting. In this case, you can see that on the HEC1 and 2 study, there's basically a 9 to 14% increase in patients that benefit from this and did not have that chemo-induced nausea and vomiting. And there's about a 10% increase of patients that did better with the moderately immunogenic. So you can really see there is a solid benefit to these patients of one less side effects that they would have to worry less about. Next slide. From these studies, these are the most common adverse reactions. On the highly immunogenic, you've got neutropenia, hiccups, and abdominal pain. You can see basically that is within 1% of the active to the placebo, showing there's not really an outlier of side effects that were experienced with Varubi. On the moderately immunogenic, you can see decreased appetite, neutropenia, dizziness. Again, the 1 to 2% within the placebo regimen, so you're not really concerned with a specific outlier there. They're still going to experience some of these, but it's not something that could be avoided in a sense. Next slide. So Varubi dosing, kind of just like we went over, it's 180 milligrams. It's 2 single dose tablets. It comes in a little wallet card. If you've never seen it, you basically open up a little mini booklet. Inside there's 2 little blue tablets. They take those 1 to 2 hours before chemotherapy. Next slide. And then the drug-drug interactions, one of the big benefits of Varubi is going to be that it does not inhibit or induce CYP3A4. So this chart shows that most patients take 5 to 6 prescription medications, 2 over-the-counter, and 2 supplement medications 3 days prior to chemotherapy. So that's 9 to 10 medications they're taking, which has a great possibility for drug-drug interaction. With Varubi, that's not something you're really concerned about other than that CYP2D6. So it has the fewest drug interactions compared to other NK1s. Next slide. It's just a quick summary slide. So it basically is the package insert if you ever need to see anything more about it. Next slide. And there's questions.
Thank you so much, Chris. So we will open it up to questions. Again, if you joined us by computer or mobile app, feel free to utilize the raised hand function. For those of you who did join by phone, unfortunately, you'll be unable to ask a question, but feel free to email us at contact@ncoda.org if you do have a follow-up question for Chris. So we'll give it a minute or so. And so it looks like we do have a couple folks that want to ask some questions. So first, we will unmute Tammy McClellan. We are going to unmute your mic so you can speak.
Hi.
Go ahead, Tammy.
I was just wondering about the dexamethasone. Is there any information from that?
I'm sorry, Tammy. It looks like your mic had cut in and out. Would you mind asking your question one more time?
The dexamethasone, I see that it's 20 milligrams. Is there any information from that? I know a month.
I apologize, Tammy. It looks like the microphone is muffled. We're having a hard time understanding the question. No. Tammy, another way also to interact is to utilize the Q&A box. If you wouldn't mind typing it there, I apologize, but your microphone is not allowing us to hear your question. But we will move on to the next question, and feel free to type that into the Q&A box. So it looks like we do have a question, Chris. The question says, what are some clinical pearls, so to speak, of the oral formulation of Varubi that members should walk away with today?
So I think kind of the big thing to pull away from this is its long half-life. So you're really covering the patient through that delayed phase that can be sometimes the worst aspect of the chemotherapy, as well as that drug-drug interactions, because we know that patients aren't always just getting their chemotherapy. They may have other comorbid conditions going on. So it's really nice to not have to be concerned with drug-drug interactions and changing the current medications that they have into something else if they're well controlled. So it really makes it simple for the patient. That's just the medication they have to take, and it basically takes care of the rest for itself.
Great. And what we'll do in the interest of time, Tammy, feel free to submit that to the Q&A. Looks like it just came in. And we'll go ahead and open it up. So Tammy asked Chris, please comment on the dexamethasone 20 milligram dose. The HEC regimen dose is normally dexamethasone 12 milligrams. Is there a reason for the increased dose?
I honestly don't know the answer to that question. I think it's just the way the study was formulated there. I'm not sure if there was a reason in that patient population, but both the placebo and active side did get the 20, so that was equivalent there.
Okay, and we do have another question. What are the benefits of Varubi versus the IV products that exist?
So Varubi, since it's an oral taken, I personally think that it gets patients more involved in their treatment, since that's something they usually have to take 1 to 2 hours before their treatment, so they take it at home typically. I've noticed a lot of patients that take Varubi, it almost starts their mental preparation when they come in, and they usually recap what was going on the last few weeks after they got their treatment and come in with questions prepared. So I really like that it kind of starts that aspect rather than the IV products. People are just sit down, sit in a chair and get it, and sometimes don't always realize what's going on in their care. So this really gets them involved a lot more.
Great. Well, thank you, Chris. In the interest of time, we do have to move forward, but for anyone who still has questions, feel free to email contact@encoda.org, and we'd be happy to reach out to Chris and try and get you those answers. So Chris, again, fantastic job.